This portion of CardioSource video news coverage of AHA 2010 is brought to you by Novartis Pharmaceuticals Incorporated.
Chicago's McCormick Place Convention Center is a magnet for thousands of people attending the American Heart Association's Scientific Sessions 2010. Hello and welcome to CardioSource Video News. I'm Dr. Randy Martin. Now, one of the biggest late-breaking clinical trials of this conference is out today, and we're going to have an in-depth look at how it will impact your practice. Our panel today includes Dr. Deepak Bhatt. Deepak is Associate Professor of Medicine at the Harvard Medical School and is also Chief of Cardiology at the VA Boston Healthcare System. And Dr. Tony DeMaria. Tony is Professor of Medicine at the University of California in San Diego and is Editor-in-Chief of the Journal of the American College of Cardiology. The trial that everybody's been talking about is called GRAVITAS. And this trial looks at whether patients who had undergone PCI and who were non-responders to clopidogrel, and it looked to see if a higher dose would make a major difference in outcomes compared to standard dose. Tony, what's your take on this?
Well, as you say, Randy, there's a number of patients who just have high post-treatment platelet reactivity, and they're predisposed, we know, to late-stent thrombosis and to other events. And so the concept here was, in identifying those patients, could you double up on the dose of clopidogrel and reduce the number of events? And I guess fast forwarding to the end point, the answer was no, that doubling the dose did not, in fact, make any difference in the end point events. It has implications, obviously, to that strategy, points us to perhaps using other agents rather than double the dose of clopidogrel, and has some implications about the approach to personalized care, whether or not measuring the response to clopidogrel is of great importance.
Deepak, what's your take on this?
Yeah, I would agree with all those comments. I think it's an important trial, and as you said, one people have really been waiting for. It doesn't support the concept of doubling the dose of clopidogrel based on this particular point of care assay. But on the other hand, the statistical power was relatively limited, so it doesn't totally rule out that strategy either. Furthermore, I don't think it supports routine point-of-care platelet testing. Even though it seems to be somewhat useful to demarcate risk, it doesn't yet allow us to guide therapy.
So you think both points then could make a difference in practice?
I think so. I think really doctors, for the most part, ought to wait for the results of ongoing trials to determine whether they should be routinely testing point-of-care platelet reactivity.
Tony?
Well, what's really fascinating, Randy, is that they applied the point-of-care testing for the single initial event, but then, having doubled the dose, they really didn't check to see if they could then subdivide patients into those who responded to twice the dose and those who didn't. So I guess that remains a little bit of an unknown here.
So, are you saying that, in essence, then, if without measuring it, that we don't really know who responded and who didn't?
Well, that's a possibility, since we didn't measure it. That may, in fact, be a group of patients in that group where it was doubled up that did respond, and perhaps they did better, but we don't know that, at least not from these data.
In fact, data published in JACC by Bonello et al. Suggests that you can overcome quote-unquote clopidogrel resistance if you keep increasing the dose enough in many patients, though not all. So I think we really need the results of ongoing trials to figure out, A, whether it's worthwhile routinely measuring platelet reactivity, and B, what strategy we should use, whether it's increasing doses of clopidogrel or using the more novel agents, things like prasugrel or ticagrelor.
So if I'm an interventionalist and I'm saying I'm confused, what should I do? What should I do at this point?
Well, I think the simple message really is that there's no mandate as of yet to routinely test point-of-care platelet reactivity. It's theoretically appealing. Personalized medicine, I think, is where we're headed in this field, but we're not there yet.
Tony, what's the take-home for the interventionalist?
Bottom line is don't double up at the moment you have no evidence that it'll benefit you.
Great. Okay. So coming up, we're going to take a look at a trial that examined the long-term safety of drug-eluting stents versus bare metal stents. So stay with us.
Special thanks to Novartis Pharmaceuticals Incorporated for supporting continuing coverage of CardioSource Video News at AHA 2010. This is CardioSource Video News coverage of AHA 2010.
Welcome back. One late-breaking clinical trial that may put to rest the debate about the safety of drug-eluting stents versus bare metal stent is out, and we're going to take a look at it. And this is called the Basket-Prove trial, and it looked at the question of whether drug-eluting stents might actually increase the risk of heart attacks or deaths years after they were implanted. Deepak, tell us a little bit about this.
Yeah, this is a very well done study by the group in Switzerland, Matthias Pfister et al., the Basket group, and what they did was examine patients, consecutive patients, a little over 2,000, and randomize them to one of three different stent types: a bare metal stent, an everolimus-eluting stent, or a second-generation drug-eluting stent, or a sirolimus-eluting stent, a first-generation drug-eluting stent, and then followed them for up to 2 years. And overall, for the rates of death or myocardial infarction, the primary endpoint, there was no difference. So reassuring data that there was no late safety signal, at least out to a couple of years, with respect to drug-eluting stents. And interestingly, not showing a difference between the second or first-generation drug-eluting stent.
Tony, I'm sure you all have had a lot of papers in JACC about this. What's your take?
Sure. Well, I think there are three issues here, Randy. The first one has to do with the safety of drug-eluting stents, and clearly they proved to be safe. The second one has to do with cost, because if a bare metal stent is about equivalent to a drug-eluting stent in a large vessel, then you're going to use the cheaper stent. And the third one is bleeding, because there's lots of patients who come in who are at high risk of bleeding that you wouldn't like to give aspirin and clopidogrel for an extended period of time, where you'd really like to use a bare metal stent and give aspirin and clopidogrel for a shorter time. The problem here is that they gave aspirin and clopidogrel for a whole year, even to the bare metal stent. So unfortunately, we don't have evidence that a strategy of shorter duration of antithrombotic therapy with a bare metal stent would be equivalent.
Deepak, these were in larger vessels, though, weren't they? And does that make a difference?
So for the most part, these were coronary arteries between 3 to 4 millimeters in diameter, and at least in that context, these results hold up. In smaller vessels, maybe the results would be a little bit different. I should point out, however, even for the endpoint of target vessel revascularization in this study, as has been seen before, drug-eluting stents did beat bare metal stents, though that margin of victory was relatively narrow. So again, I think the cost-effectiveness argument could be brought into it. Certainly, though, this study, I think, is reassuring to interventionalists and the broader cardiology community, because there wasn't a late, or I should say very late, stent thrombosis signal, that is, stent thrombosis after 12 months, despite the fact that for the most part that clopidogrel was stopped at 12 months. So even though it doesn't answer the bare metal stent question of can you go shorter than 12 months, it does reassure us that for drug-eluting stents, 12 months might be enough within the context of large coronary arteries and a couple thousand patients.
So I'm hearing, I'm sort of getting different versions here. Tony, I mean, and you're saying the same thing, but Tony, so again, going back to how it might impact practices, do you think this data might impact practices one way or another?
Well, I think for us, we've already adopted a strategy that in a large vessel and a patient with some bleeding risk, that in fact we're routinely using bare metal stents. And although it's not 100% the same as the protocol, I think we have some confirmation that that's a reasonable approach. And I would anticipate that more bare metal stents will be used based upon these data, even though there may be a slightly higher risk of restenosis.
Deepak, what's your sort of take-home message on this trial, and then what it means to the practitioners?
Sure. Well, first of all, I think it shows that stents, modern stents, and this was a cobalt chromium stent, which is a thin strut stent and a particularly good one, I think. But it shows that modern stents are pretty good. Right. That is, in terms of results, I don't think it's such a critical omission to say, oh, this patient's getting a bare metal stent. I don't think they're getting cheated out of something if they get a bare metal stent and not a drug-eluting stent. And that's a reassuring message, and certainly for patients that are high bleeding risk, I would say that's the way to go, especially if they've got a large coronary artery. Likewise, another important message is there wasn't the difference between first and second generation stents seen in this study, as has been seen in others. So I think we still do need more research to figure out which is the absolute best stent to put in patients. But this is very reassuring data that any of the 3 stents used are pretty good.
Tony, final thoughts?
Well, certainly for the rest of the world outside the United States, Randy, I think this is very reassuring to them because in third world countries, they're typically using bare metal stents, and so a valuable study from that regard.
Super. Okay, well, thank you both. And we want you to check in with cardiosource.org for more information on these late-breaking clinical trials. Thank you for joining us.